Hi, this is Dr. Rosen Carroll. I'm the Director of Breastfeeding and Lactation Medicine at the University of Rochester. You're watching this presentation because someone along the way has worried that your baby might have a tongue tie that could be impacting their feeding. So we're going to talk a little bit about what is tongue tie and what we do about it here if we need to. First, let's talk about what is a tongue tie. Everyone has a lingual frenulum, which is the band under your tongue. You should be able to see it if you look in the mirror or feel it if you put your finger under your tongue. In 1 out of 10 babies, this lingual frenulum is either too far forward or tighter down than it should be, and we call this a tongue tie. Not all of these tongue ties will make breastfeeding difficult, so about 50% of these will cause trouble with breastfeeding. When we talk about tongue ties, we talk about them in terms of anterior or posterior. We start with type 1, which goes all the way to the tip. Type 2 is slightly behind the tip. Type 3 is thin but farther back. And type 4 is also referred to as a submucosal or a posterior tongue tie. It's difficult to see without lifting up the tongue, and the type doesn't correlate with how well the tongue works. So we have seen type 1 tongue ties with babies who are not having any feeding difficulties, and type 4 tongue ties in babies who have significant feeding difficulties. There are a few pretty common scenarios for tongue tie with newborn babies. Sometimes you'll have a high-tone baby where the parent has had a rough delivery, lots of nipple pain, vasospasm, or a squashed nipple after breastfeeding. The baby might have a very small mouth, be screaming or biting at the breast, gumming or clamping down. They may have a tight neck and they may be fussy, gassy, or have reflux. Another typical scenario would be a baby with lower tone, where the mother initially has a stronger supply, but it goes down over time because breastfeeding doesn't feel like much. These babies might require waking to feed or triple feeding, and the baby might have other medical complications or show signs of fatigue. The baby could have prematurity, take time to organize a suck, be fatigued at the breast, and therefore might have trouble getting the milk out. So they might not gain weight properly or fall asleep at the breast. These are only 2 typical scenarios. There are other ways that babies can present with tongue ties. Unfortunately, we have little to no research on how tongue tie affects infant feeding outside of breastfeeding, specifically how bottle feeding is affected. In our clinical experience, severe anterior tongue tie can sometimes affect bottle-fed babies by causing difficulties with latching to a bottle, and therefore they can swallow more air, which might contribute to gassiness and reflux. Many people are worried about their baby's tongue tie and how it will impact their speech and development, and unfortunately, at this time, we have very little evidence about that. Certainly, there are older children and adults who will have difficulty with pronunciation until their tongue ties are clipped. We just have no way of knowing how often this happens. A myth is that these will stretch out over time, and they don't, but people do learn to compensate for them. Some adults with tongue tie will report trouble eating certain foods, like licking ice cream, cleaning their teeth with their tongue, perhaps leading to cavities, gaps in the teeth, as created by upper lip ties, French kissing, and other things people do when they're older. Recent evidence has shown an association with adults with sleep apnea and tongue tie. Again, it's just difficult to know how often these things happen. Just like under the tongue, there's another frenulum in the mouth at the upper lip. These we call type 1, 2, or 3. And as you'll see on the left, a type 1 maxillary frenulum, or upper lip frenulum, is a very high-lying upper lip frenulum, and type 3, on the other hand, wraps all the way down under the gum. Unlike tongue ties, we don't have very clear definitions of when these upper lip frenula are actually tied. In our clinic, what we call a lip tie is when the upper lip frenulum doesn't flex up to the nose, and I'll explain that more in the next slide. Unfortunately for lip ties, we have very little research about which lip ties seem to matter for breastfeeding. We do know that many lips look tight during latching because the tongue is tight. So if the tongue is unable to create a seal, then the upper lip will purse to try to create that seal instead. We also know that it doesn't necessarily correlate with the development of a gap at the upper teeth, because that part of the mouth has to grow down and forward as children grow and develop. Finally, for breastfeeding, flexibility of the upper lip seems to matter most in order to create that seal. And as you'll see, there are two low-lying upper lip frenula on the slide. The one on the left is very flexible and therefore has a better chance of creating an effective seal as compared with the one on the right. So because we have limited evidence, we recommend a staged approach to lip tie. We don't know exactly when cutting a lip tie will improve breastfeeding, but in one fairly large study of over 300 infants, 98% of these babies improved after having only their tongue tie clipped, and only 6% of those needed to go on and have their lip tie clipped. So when there is a tongue and a lip tie both at the same time, based on the best available evidence, we believe that the tongue tie should be clipped first, and then if symptoms persist, parents should consider having the lip tie clipped. Some parents want to consider clipping an upper lip tie first, and this may happen if they prefer their baby to have one painful procedure instead of two separated, or if there's an isolated lip tie with no tongue tie, and there are symptoms with feeding, like pain at the site of the upper lip, inability to latch, or a baby who can't get the milk out, despite other things we can try to do to help, like positioning. Another tie that some parents have heard of is called a buccal tie. A buccal tie is an attachment or frenulum between the gum and the cheek, and there's probably one in each gum cheek margin, so that would make 4 total in the mouth. We don't know how common they are, we don't know their frequency, and there are no studies showing an impact between these types of ties and poor infant feeding. Theoretically, they could impact attachment, and in the future could impact gum recession and probably are the cause of those cute little dimples. Because of the lack of evidence and some clinical situations that we have seen in which babies have had many and sometimes all of these ties released, and then experienced significant pain and difficulty feeding afterwards, at this point we believe that the risk of clipping these buccal ties outweighs any potential benefit. So if your baby is found to have a tongue tie that's causing feeding difficulty, we may recommend a frenotomy. And the frenotomy procedure is a very old procedure. There are references to it in the Bible, and these pictures are woodcuts from the 1600s showing an operative technique and instruments that are very similar to the ones we use today. And if we perform a frenotomy today, your baby will be swaddled and given cold breast milk or sugar solution, whichever you'd prefer. The tools look almost identical to how they looked in the 1600s. We lift up the tongue and clip until we fully release the restriction, which creates a diamond shape in the back under the tongue. Another technique that we can use is doing the frenotomy procedure by laser, which is a near identical procedure, just using a different tool. The other difference is that the baby's eyes will have goggles on, and parents are asked to step out of the room for safety. You'll see that the scars look very similar to scissor scars, and you see here also a picture of an upper lip frenulum that has been incised with a laser. It is important to know that we have no data suggesting that the laser is better than scissors or vice versa, and we have seen very comparable outcomes using both techniques. There is a very low risk of bleeding with laser use, and in some offices or with some providers, the parent might be asked to step out of the room. Also, dentists can perform this procedure by laser, and if so, they may use dental insurance to cover the cost of the procedure, which can be complicated if an infant doesn't have dental insurance. At our office, both procedures are billed identically. There's good evidence that the frenotomy procedure can improve the feeding experience and decrease maternal pain, but a little bit less evidence about improving the amount of milk that a baby gets out of the breast and therefore how much weight they gain. There is also a little bit less evidence, but still some, for decreased gassiness and reflux in babies. But in all of these, we do see longer breastfeeding. We call frenotomy a low risk but not a no risk procedure. As with any procedure, you could see some bleeding. If your baby bleeds more than we expect, then there are medications we can apply. In the worst case scenario, you would need to go to the emergency room or an ENT office for an evaluation to have a stitch placed under the tongue, and that is incredibly rare. It's also possible that other structures are clipped in the back of the mouth, including the muscle of the tongue or the salivary ducts. Anytime you cut anything in the body, you could get an infection. Again, this is very rare. These potentially can regrow. Our hope is that it doesn't regrow restricted, and every baby will end up with a frenulum under their tongue. There is again limited evidence about how often they regrow. Potentially 10 to 30% will regrow with some amount of restriction, but very few will need clipping again. And then finally, it might not help the problem. For posterior tongue ties, we anticipate that about 60 to 80% will improve after frenotomy. For type 1 and 2 or anterior tongue ties, we anticipate that 80 to 90% will improve after frenotomy. Frenotomy is not the only thing you can do for babies with tongue tie. There are many body workers in Rochester, like chiropractors and craniosacral therapists. There are occupational therapists, speech and feeding therapists, as well as physical therapists that might be able to help, particularly if the baby has any neck tightness. Many people will also try nipple shields or supplemental nursing systems as shown. Some people will be triple feeding or pumping and feeding. And what we recommend will depend on the type of issue that your child is facing while feeding. The tongue tie procedure is painful. Afterward, newborn babies and calmer babies tend to have very little fussiness, whereas older babies or fussy babies can have a few bad days. In order to help them, you can do lots of skin-to-skin, feeding and cuddling. We will let you know what dose of Tylenol your baby would need in case they have trouble settling at night or are having trouble eating. Generally, people will only need to use 1 dose of this. It's important not to mask a fever and to remember that a fever is a medical emergency in babies under 2 months of age. Bleeding at home after a frenotomy is very rare. If this does happen, just have your baby suck on something like a pacifier or breastfeed. At the worst, you could apply some pressure with a cold washcloth while giving a call to your pediatrician. Your baby may also spit up some pink, which would be blood that they swallowed, or pass a black stool, which is again blood that they swallowed and digested. We do recommend that you slowly normalize breastfeeding. For type 1 and 2 tongue ties, breastfeeding can get better very quickly, but for posterior tongue ties, it can take a little bit more time. So we recommend that you continue to feed the baby the way you've been feeding them while you work on normalizing breastfeeding. Scars do turn white before they turn pink again, and this is normal. If your baby has a little jaundice, the scar might even have a yellowish tinge. Signs of infection include pus and pain. Sometimes babies will refuse to eat, sometimes they won't wake up to eat, or they might develop a fever. This is very rare, but if any of it happens, either call our office or your pediatrician right away. In a few studies of older children, suck training afterwards was a good way to help the tongue get stronger and reestablish function. So we do recommend suck training for your baby. But because there's no evidence in this age group, we want it to be gentle and fun. If it causes your baby any distress, please don't do it. The way that we do it is by washing our hands, putting breast milk, sugar water, or formula on your finger, and we'll teach you how to do several things. First, we'll have you tap on the lips to encourage your baby to stick out their tongue more. Then we'll teach you how to do a suck tug of war or push back on the baby's tongue for a few seconds while they're sucking until you can feel the tongue coming out and cupping and waving. Lastly, you can rub the lower gum side to side to watch the tongue follow, helping those lateral muscles of the tongue to get stronger. We recommend this about 3 times a day for 1 to 2 weeks. If you have any questions, please let us know. Our goal is to make sure that you're comfortable with whatever decision is best for you and your baby.